Hello, everyone. My name is Brian Peterson. I'm a speech-language pathologist at the University of Iowa Hospitals and Clinics. Today, I'll be talking about swallowing, saliva, and voice changes related to Parkinson's disease. I am an employee of UI Healthcare and do receive a salary. However, I have no other relevant disclosures. And 4 topics that I'll be discussing today, as I mentioned, are swallowing, weight management, saliva control changes, and voice changes in Parkinson's disease. And my main objectives are really to increase understanding and knowledge of general changes which can occur with Parkinson's disease progression. And I'll also discuss some more specific considerations which can be made in cases of advanced Parkinson's disease. So without further ado, getting into the topic of swallowing and weight management. One word that we use in our field a lot is dysphagia. And dysphagia is really a fancy word for swallowing changes which affect the safety and or efficiency of eating and drinking. And this is something that's really prevalent in patients with Parkinson's disease. Studies have suggested that 18.5% all the way up to 100% of patients with Parkinson's disease have the presence of dysphagia. And, you know, obviously that's a really wide range. And those numbers are kind of so wide simply based on the way that the researcher themselves were defining dysphagia and categorizing it. However, it can be present in any stage of Parkinson's disease, but does become more prevalent in the later stages, such that aspiration pneumonia is the leading cause of death in patients with Parkinson's disease, to the point that they are 3.8 times greater, or have a 3.8 times greater risk of developing pneumonia related to aspiration. And we'll go into that, what that means a little bit more here in a little bit. But when we talk about, okay, how do we know if somebody's having more difficulty swallowing or is having some dysphagia? You can see some of those signs and symptoms listed here. Is it taking longer to eat? Is there decreased ability to control stuff within the mouth? Are we seeing some overt signs where a person is coughing or clearing their throat a lot, or choking even while eating and drinking? Are there voice changes which are occurring, going from a normal sounding voice to kind of a wet, gurgly, like we're talking underwater type of quality to the voice? And then there's some physiological changes, weight loss, fever, respiratory changes, those types of things. You know, and really, if we're starting to see any of these things occurring with our patients, an evaluation by a speech-language pathologist is really crucial, so that the appropriate evaluation can occur, and then the most appropriate recommendations or strategies or modifications can be made to help reduce the risk of aspiration and aspiration pneumonia. And so I mentioned, obviously, a few slides ago that aspiration pneumonia is the leading cause of death in patients with Parkinson's disease. However, I wanted to take kind of a half step back and really talk about what aspiration itself means. And so when we're talking about it in regards to swallowing, it means that material, whether that be food or liquid or saliva even, progresses past the level of the vocal folds within the throat, which then leads to a spontaneous bodily response, that being, again, a cough, throat clear, hack, sputter, that type of thing. And aspiration can be reduced to a number of different things. It can be related to reduced oral control, difficulty moving stuff around in the mouth or keeping it in the mouth until we're ready to swallow. Reduced strength of the throat musculature, so that everything's not getting squeezed through fully when a swallow is triggered. Incomplete vocal cord closure. There's some pressures that are generated within the throat that create that safe swallow, and if those pressures are disrupted at the level of the vocal folds here, that can affect the safety. And then in general, incoordination of timing. And what I mean by that is, you know, perhaps that there's some material moving from the mouth into the throat, and the throat part of the swallow isn't quite quick enough or isn't starting on time. And so those levels of protection that are built in can can be negatively affected. And when we're thinking about this and with specific regards to Parkinson's disease, impairments can occur in any in one or all of those areas that I mentioned earlier. However, another component with Parkinson's disease which can arise are these cognitive changes. And so by that, what I mean is the increased impulsivity, decreased attention to food or liquid in the mouth. And that can also negatively affect aspiration risk. As I mentioned, that aspiration in a normal swallower will result in those spontaneous bodily responses. However, there has been research that has demonstrated that patients with Parkinson's disease, especially as the disease progresses, that spontaneous response is less readily triggered, such that material is getting past the level of the vocal folds without that spontaneous response, which we would categorize as silent aspiration. And that can be particularly concerning because then that material is not able to be cleared out of the airway. Susan Langmore in the late 90s did a study that looked at dysphagia and aspiration and really asked the question, how important is the presence of aspiration to the development of aspiration pneumonia? And what they found is that there are some stronger predictors for the development of aspiration pneumonia: decreased mobility, dependence of the patient for their activities of daily living, cares, and feeding especially, and poor oral health. Now, we know that patients with Parkinson's disease can certainly experience decreased mobility and increased dependence on cares. And the other piece there, that poor oral health is very important. So what I mean by oral health is brushing, flossing, using mouthwash, those types of things. If one doesn't have natural dentition, making sure that dentures or partial plates are cleaned regularly, and that the gums, roof of the mouth, tongue, those sorts of things are all cleaned regularly. There's some data out there to show that increasing oral care just by once a day can reduce the risk of aspiration pneumonia by 50%. And some other contributors to the development of aspiration pneumonia is poor overall health, poor overall condition, and then decreased cough strength. Again, I mentioned on the previous slide that when in the presence of aspiration, when sensation is intact, a cough can help to clear material out of the airway. But if the cough, even if the cough is triggered, but it's not strong enough, that doesn't fully clear things out. And we'll talk a little bit about increasing cough strength and strategies for that here in a little bit. But when we think about treatment strategies, I kind of touched on it, I think, a little bit at the beginning, in that early identification is very important. And so if we're starting to notice some changes to eating and drinking behaviors, getting in with a speech pathologist so a formal evaluation of the swallowing can occur to really evaluate that swallow function, evaluate the risk of aspiration, and if there are any compensatory strategies or modifications that can help reduce that risk. One of those strategies can be, modifying the environment, so positional adjustments, and this can be particularly effective when collaborating with our physical therapy colleagues. So making sure that a patient is sitting upright, that they're positioned optimally in the eating environment, reducing distractions so that the patient can really attend to what's going on in the mouth. That means, turning off the TV, turning off the radio, maybe not eliminating conversation, but, kind of being very mindful of the need to pay attention to what's going on in the mouth. And then collaborating with our occupational therapy colleagues to see if there is a need or benefit of adaptive silverware, dishes, those sorts of things, to help optimize the ability to feed, or the ability for the patient to self-feed. With regards to specific swallowing therapy approaches or therapy approaches targeting the swallow mechanism, the McNeil Dysphagia Therapy Program is one protocol that is out there, and it's a program that's focused on increasing swallow safety and efficiency with an intense number of repetitions during each therapy session to really sort of overload the system and increase muscle change in that way. There are other sort of less intense swallowing exercises and strategies to help maximize muscle strength and airway protection. The Iowa Oral Pressure Instrument, or IOPI, is a strategy or a device actually that targets tongue strength. And then this expiratory muscle strength trainer, or EMST, is a spring-loaded pressure-generated resistance device that was initially developed by some research scientists down in Florida, initially aiming at increasing cough strength. And really kind of increasing that respiratory drive with a cough. However, as they started getting into this research, particularly with patients with Parkinson's disease, they were seeing some benefits with overall swallow function as well. So decreased penetration aspiration scores, decreased objective measures of aspiration, improved force generation with that cough, and improved timing of subglottal pressure generation. And so as I mentioned, the vocal cords come together in a swallow and create some of those pressures, and that pressure ended up being a little bit higher in those patients that participated in this expiratory muscle strength training. There are some other modifications that can be made to the food and fluid themselves that can improve overall swallow function, or excuse me, overall swallow tolerance, safety, and efficiency. There are some modified diets, modifying the foods, so making sure that they are minced and moist or are broken down easily within the mouth. Sometimes thickened liquids may be indicated so that they travel a little bit slower, move through the mouth and throat just a little bit slower to allow things to catch up. And sometimes changing how medications are administered. So crushing them and putting them in applesauce, or just putting the whole pill itself in applesauce or pudding or yogurt or something like that. Sometimes medications can be changed to liquid form so that they can be taken a little bit easier. And in some cases, receiving primary nutrition and hydration through a gastrostomy feeding tube called a PEG tube may be most appropriate. And it may end up being most appropriate due to swallow inefficiency and or safety. But it should be mentioned that receiving a PEG tube doesn't necessarily mean that a patient is no longer at risk for aspiration, but it can be beneficial in terms of reducing that risk of aspiration with food and liquid, and then can also help in the area of weight maintenance. And if we think about how weight maintenance can be affected in patients when they have, sort of a progressive disease, as dysphagia symptoms increase. Again, we mentioned that dysphagia is more prevalent, more prominent in those later stages of Parkinson's disease. As those symptoms increase, PO intake tends to decrease. I mentioned on the last slide about modifying diets. That can be beneficial in that it makes the safety a little bit better, but it can make meeting those nutritional needs a little bit more challenging because potentially the food is less palatable. It can result in decreased nutritional value when we're manipulating foods in that way. And then some of the safe swallow maneuvers or strategies can kind of further complicate the mealtime process and take some of the pleasure and motivation out of eating and drinking, which can again affect overall weight maintenance. Now, I'm not a dietitian, but I have picked up and learned about a few different tips and strategies that can be helpful with regards to weight maintenance with really any patient population, but especially in these patients where dysphagia can be present. focusing on foods that are high in nutritional value, so lots of protein, good calories, good fats, those sorts of things. Sometimes doing smaller, more frequent meals throughout the day can be beneficial, rather than sitting down and feeling like I have to finish this huge plate of food, because we know that fatigue can set in when meal times are longer. Considering supplemental beverages, so Boost, Ensure, homemade protein shakes. There are a number of other things that can be considered, but they can really help to meet those nutritional needs, especially when they're kind of taken interspersed throughout the day. So one can still eat those 3 square meals a day, but have a shake in between to kind of supplement things. And then, as I mentioned too, considering placement of a PEG tube to help supplement what a patient is able to take by mouth, or in some cases provide primary nutrition and hydration. You know, as I mentioned, I am not a dietitian, but I would really encourage patients and family to advocate for referral to a dietitian if there are concerns for weight loss or ability to maintain weight, because the dietitians are really skilled at looking at what types of foods, especially in the context of a patient with Parkinson's disease, what types of foods would be most beneficial and appropriate from a nutritional standpoint, but then also calculating based on patient's height, gender, weight, comorbidities, all those different types of things, how much from a numbers standpoint one should be focusing on as far as protein and calories are concerned. Another consideration that I wanted to discuss, or at least introduce today, you know, obviously patient-centered care is very important. And I came across this quote when researching this for this presentation. And I really thought that this quote was particularly relevant for patients with Parkinson's disease and really neurodegenerative diseases in general. So it states that patients who have capacity have a right to choose how they feed or are fed. Those who lack capacity may have decisions made in their best interest, or may have advanced directives stating their wishes in the event of loss of capacity, which ought to be respected. You know, I've worked with a lot of patients with head and neck cancer who are going through chemoradiation therapy. I've worked in the University of Iowa Healthcare ALS and muscular dystrophy multidisciplinary clinic, and have many times asked patients, you know, point blank, so where do you stand on the PEG tube spectrum? You know, are you for it and we'll go ahead and get one placed? Are you totally against it, want to avoid it at all costs? Or are you kind of in the middle, where you'll consider it or get it if and when needed? And I think that conversation is very important, because it identifies that this may be something we need to really think about in the future, and B, helps to kind of shape some of those modifications and how they are presented. But the reason that, you know, this patient-centered mindset is important is that, obviously, as I mentioned before, diet modifications can affect motivation and willingness to take enough by mouth. And the recommendation of a feeding tube itself can really kind of negatively affect quality of life and that patient autonomy. And swallow function, we know, is going to continue to deteriorate as these degenerative diseases, these progressive diseases, progress. And so, you know, it's not the case where it's an acute injury or process happened and we expect it to get better, and so the feeding tube tends to be more short term. You know, it is a longer term process, and so really having, you know, important communication between the patient, family, multidisciplinary team members as far as where they're at on this feeding tube discussion, and educating with regards to the risks of taking food and fluid by mouth, and the risks of aspiration and that sort of thing, so that everybody's kind of on the same page. Some of those conversations and accepting that risk can be appropriate for some patients. So moving along to our second area of discussion here, sialorrhea and drooling, these salivary control changes. And so these two terms, sialorrhea and drooling, are a lot of times used really synonymously, but they mean or refer to two different things. Sialorrhea being overproduction of saliva, and drooling referring to the loss of control of saliva within the oral cavity. And in terms of Parkinson's disease, these two things tend to be more prominent in the off period. So when those Parkinson's medications are wearing off, patients may feel like they are producing more saliva. However, what's more likely to be happening is that the frequency of swallowing and or ability to manage saliva in the mouth because of reduced mobility of the tongue or what have you is more likely what's changing. Several studies have shown that patients with Parkinson's disease actually produce the same, if not actually a little bit less saliva than normal controls. However, the speed with which it is excreted in the presence of a stimulus is quicker. As we know, decreased saliva control can have some negative quality of life effects and can affect the ability to manipulate food or fluid within the mouth. And so there are several strategies, behavioral strategies, that we as speech pathologists would work on with patients. Again, in collaboration with our physical therapy colleagues to optimize positioning, head, trunk control, those sorts of things. Some oral motor exercises really targeting lip closure strength and lingual strength and range of motion can be beneficial. And sometimes it's a matter of just increasing the frequency of swallowing. So recommending taking regular sips of liquids during non-meal times, or increasing the number of just non-nutritive swallows that a patient is doing. And that can be benefited with setting alarms or prompts or what have you to kind of increase that frequency. However, motivation can really be a factor with patients and or caregivers, and that can affect the success of these behavioral strategies. And so if that's the case, or if it's just not managing things in the way that a patient or family would want, there are some medical strategies that can be pursued. Some prescriptions to decrease saliva production, Botox injections to the salivary glands, or radiation therapy are all strategies that have been pursued and studied. Botox injections appear to be the most effective, but this would be a conversation to have with your medical team, with your doctors, to see if this is a concern, to see what would be most appropriate for you or your family. And our last area here is hypophonia, which essentially means soft voice. And before we talk about, okay, how do we manage this soft voice, I wanted to take a second to discuss how one produces voice in the first place. And so there are some requirements that we have to have. One is adequate respiratory capacity, such being able to take a deep enough breath. 2, adequate respiratory drive, enough strength to push that air out effectively to get the vocal folds to vibrate, but then also intact laryngeal anatomy, vocal cords that are moving and are coming together to produce voice. And so in the idea of a picture is worth 1,000 words, I wanted to show what that would look like. And so this is a scope exam looking at the vocal folds. The two pieces of tissue there that are vibrating in the middle of the screen are the vocal folds. You can see how they open up when she goes to take a breath and comes together when she goes to use the voice, and they're then set into vibration. And so again, a picture is worth 1,000 words, but I wanted to and I wanted to provide that picture for you. But when we're talking about hypophonia, it is a component of hypokinetic dysarthria, which is the speech pattern most associated with Parkinson's disease. And it's characterized by decreased loudness, as I mentioned, which is related to decreased airflow or respiratory drive from the lungs, and or incomplete vocal fold closure. Other characteristics that you can see listed there of this dysarthria type include monotone voice, monoloudness, and decreased articulatory precision. And there are two main behavioral management protocols that are have been studied and pursued for hypophonia. The first is this Lee Silverman voice therapy, and this is a therapy protocol that's been the most studied and recommended, I think, voice protocol strategy to this point. But it focuses on speaking loud, so recalibrating the amount of effort needed to achieve adequate vocal intensity. It is an intensive program, so 4 sessions a week for 4 weeks, and then a home program of exercises. There has been some evidence to show that it actually can improve overall swallow function as well, because some of the same mechanisms within the throat are utilized and strengthened. One of the drawbacks to it that has been identified in the literature is that it doesn't address the prosodic impairments, so monotone, monoloudness, those sorts of things. And you also need a laryngoscopic evaluation to rule out vocal fold anatomy prior to starting this behavioral protocol. The second main behavioral strategy protocol is speak out and loud crowds. So this focuses on speaking with intent. And so it not only addresses the loudness component, but also the intonation variability. So that monotone, monoloudness. It is also an intensive program. So 3 sessions a week over the course of 4 weeks. Or 3 sessions a week for 4 weeks, excuse me, with a home program as well. But after the patient completes the one-on-one sessions, they are invited to join the Loud Crowd, which is a once weekly group therapy opportunity to continue utilizing those skills learned with other patients with Parkinson's disease. There have been some medical approaches that have been attempted or studied with regards to changes in voice. So your medical, levodopa administration and or placement of a deep brain stimulator. And, these are really good at controlling some of the limb and motor controls. However, don't show as much benefit to voice control. So behavioral management is the mainstay of management of hypophonia. In patients that have a vocal fold abnormality, vocal fold injections can be considered. However, that behavioral management is still important so that we can make sure that we're maintaining that adequate respiratory drive and that respiratory control for voicing. If hypophonia or decreased clarity of speech dysarthria has progressed to the point that verbal communication is not optimal or possible, use of augmentative or alternative communication strategies and devices may be appropriate. And these can be anywhere from a low-tech to a high-tech strategy or device. And what's really important is collaboration between speech pathology, occupational therapy, and sometimes physical therapy to optimize the setup and access of these devices and strategies. And so in summary, the take-home points today is that early identification and management is key, particularly with swallowing, saliva management, weight, and voice. If you're noticing some of these changes or changes in any of these areas, advocating for an evaluation with a speech pathologist is very important. A formal swallowing evaluation can identify the area of impairment and then allow for most appropriate management strategies to be recommended. Behavioral and medical management can help the control of saliva. However, speech and voice therapy is the mainstay for hypophonia and dysarthria. I have a couple slides of references that I use, but I want to say thank you for tuning in, and I look forward to answering questions at the end.